Afternoon, everyone, and welcome to today's AUACS webinar. We are delighted to have participants joining us from across Europe and beyond to discuss a truly groundbreaking initiative in pediatric health. Italy has made history as the first country in the world to introduce a national law mandating mass screening of celiac disease and type 1 diabetes in children aged 2 to 10 years old. Under the framework of Italian law 130/2023, designed to ensure better care for children living with these two chronic conditions, a pilot study has been conducted in 2024 involving over 5,000 children across 4 regions in Italy. And this pilot study has already shown remarkable results, which will be presented and discussed today during this webinar. I want to acknowledge and thank the Italian Celiac Society. This is a full member of AUACS that has played a leading role in raising awareness among families and also healthcare professionals about this landmark initiative. And we really appreciate all the efforts they have done in this work. And so now to provide insight into this legislative journey and the vision behind this initiative, it is my great honor to introduce Onorevole Giorgio Mule, who is Vice President of the Italian Chamber of Deputies and one of the main promoters of this pioneering law. Thank you so much for being here with us. I would also like to extend a warm welcome to and acknowledge Marco Silano and Olimpia Vicentini, both from the Italian National Institute of Health, and who will be also presenting the details of this national screening program and the pilot study results, respectively. Without further delay, join me in giving a really warm applause and welcome to Giorgio Mule. Thank you so much.
Thank you to you. Good afternoon. Now, you heard me? Yeah, is everything right? Okay. So thank you so much again, Mr. Rubio, and good afternoon to everybody. Why I'm here? Let me thank you before your organization, the Association of European Celiac Society, and also the operational arm here in Italy, so the AIC, the Association of Italian Celiac, and the management, and obviously Dr. Silano, Dr. Piacentini, and everybody who stay with us in this afternoon. I will ask just a few words. I don't know. You told me thank you because I'm here. Is the opposite. I have to thank you, all of you, and I have to thank the community of celiac, the Association of Celiac of the Diabetes Type 1, because it's from them that this law was born. This law was born because a community from association of patient familiars, a community of scientific side, and at the final political side, stay together and say, okay, what we can do now to do a very mass prevention about celiac and diabetes type 1. We observed with Dr. Silano, the Institute of Wealth here in Italy, the Ministry of Wealth, the data. We saw the data that they year by year were to increase, and the increase. And we thought how we can have a monitor about the kind of percent. So the law was born for this reason. And in any part of the world, as Mr. Rubio said before, at the law like us. So it's a revolutionary law, but it's a very simple law, like the Columbus egg. So Columbus egg is very simple. You know, problem very strange. Many times needs a very solution like a principle or no problem solution. So the solution were to start and to have a mass screening for celiac disease and diabetes type 1 became from zero. So when we have a newborn in our society from 0 to 17. Because as you know, in this kind of pathology, the pathology diabetes and type 1 become near 12, 14 years old. So prior we know if we have people who are who have the sign of this pathology of diabetes 1 and celiac before we can assist them, and we can arrange we can have a follow-up, not only with the kids obviously, but fundamentally with the family, to take the family by hand, to have an education when diabetes type 1 or celiac manifest in the specific. So as Mr. Silano, as Mrs. Piacentini will tell you about the initial results of our screening across for a region where Lombardy, Sardinia, Marche, and Campania, we have results that we they definitely surprise in a good way, surprise in a bad way, because we and I am firmly convinced that in 2050 we have like a pandemic. We talk about pandemic, about COVID or other things, but the new pandemic of our era will be celiac and the diabetes type 1. And as Dr. Silano and the scientific community know, the age was not go up, but go down when the pathologic go. So what we do now, we finished as our colleague, our friends will tell you that the first phase. Now we have to start the big challenge. The big challenge is in all around of Italy from January 2026, and we start with we start with people from 4 to 6 or 6 to 8, and we start to have the mass specific our mass screening, and we start to collect this very important fundamental role of the data. We collect the data from all over Italy, and we see where, why, and when we have the new patient. So it's a huge work. It's a work in progress. A work in progress that we made together, and I underline together with medics, paramedics, scientific association, and every piece of this puzzle were fundamental for the success of this law that, as you know, we're going to share all around the world, from Europe to US to Asia. So we are proud of this, and we will be proud when the next year we going to have another webinar to say the results that I told you. I'm afraid when I saw the results in a way. In the other way, I just thought we did the right things that we had to do. So thank you to you, Mr. Rubio. Thank you to everybody. I will stay in touch with you and hear the fundamental news that Dr. Silano and Dr. Piacentini will tell to us. Thank you so much.
Thank you, Veronica. For the floor, Honorevole Moulet. Dear colleagues, thank you very much to the Association of Celiac Patient Society across Europe to inviting me and for having me today to this important webinar that give us the opportunity to present you the results so far of the propedeutic study about the screening, the pediatric screening program in Italy. As Honorable Moulet said, we at Italian Institute of Health had the duty to develop and to set the standard for the protocol of the pediatric screening across all the country. And we had to set the protocol to be implemented at the level of each region and autonomous provinces in Italy to carry out the screening. We have to thank Honorable Moulet to boast and to support the law 130 approved by the Italian Parliament in December 2023. This law set the Italy as a standard globally, worldwide, for the screening of both diabetes type 1 and celiac disease. Several countries across the globe have tried before to develop a national screening program, but we are the first in the history and at the global level because this program was carried out at national level. So each regions, each autonomous province has the duty to offer the screening to the newborn in their own territory. And this is the first screening program to integrate and to address simultaneously both diabetes type 1 and celiac disease. As you know, these two conditions are tightly related and cross-linked each others. We don't know exactly why. For some common genetic background, for some common environmental triggers, but as matter of the fact, they come together into a population. So it's very important to perform a simultaneous screening of both these conditions. So the competent authority in Italy to develop a national screening program, of course, is the Ministry of Health, and they give us the mandate to study a sustainable protocol of the screening that can be carried out at national level. When I say sustainable, I mean sustainable from first of all, logistic point of view, because it's very important that we propose to regions something that can be carried out with the resources and the funding provided by the law. Is sustainable by an economic, of course, point of view, but also that is feasible and also is highly acceptable by the population. Later, Olimpia Vincentini will present some data about how our screening, our program has been accepted by the families and by the population. I can anticipate. I hope that Olimpia doesn't get mad with me because I spoil some results, but I can anticipate that the general population does accept this screening very, very well. And also, Olimpia also will present these results, but I would like to stress them. We have a high acceptance rate of the screening, not only in families with a consanguinity for celiac disease or diabetes type 1, but also in families that don't have consanguinity, that don't have any relatives with a previous diagnosis of celiac disease or diabetes type 1. So it means that what the regions and the autonomous provinces will offer in the upcoming years to the population is something that the population is prone to accept and participate in. So, as Honorable Moulet has already presented, we have chosen 4 regions that are evenly distributed across Italian peninsula, and the population we have offered this screening in this propedeutic phase is closely like the general population. So we have some results that can be brought to a higher scale to the general population. So now I am glad and thank you again for this invitation. Thank you again, Honorable Moulet, for giving us this opportunity and to bring Italy forward at global level in this field. And I'm glad to hand over to Olimpia Vincentini, that is a colleague at the Italian National Institute of Health, that with Flavia Pricci, that unfortunately is not able to participate to this webinar this afternoon, but Olimpia Vincentini and Flavia Pricci are the driving force of this propedeutic study. Without them, the results we are going to discuss today will not be generated. So I'm glad to hand over to Olimpia for further and in-depth description of the results of this phase of the study.
Thank you so much for the invitation, and I'm very glad to participate, and thank you to Dr. Honorable Moulet for his support. Thank you, Marco, also for your support. We're very happy to provide some insights from the DIScreen project. Okay, so we started this project, and we are now it's ended, but we are very happy to give some insight from the preliminary results.
Yes.
As already mentioned, the DIScreen pilot project represents the first Italian experience of pediatric screening for type 1 diabetes and celiac disease. And the study was initiated following the recent Italian law, which introduced the screening for these 2 diseases in the general pediatric population, and the objective was to identify children at risk of presymptomatic diabetes or undiagnosed celiac disease. As we can see, the primary aim of the law is to reduce the onset of type 1 diabetes with diabetic ketoacidosis and the prevention of non-gastrointestinal complication of celiac disease by a prompt treatment of newly diagnosed celiac disease by gluten-free diet. To implement the law, the pilot project was performed to evaluate the feasibility, the acceptability, and the sustainability, as Marco was saying, of a national screening program with the Italian National Health Service. So we want to go to the territory, and the main outcome assessed were in this year the family adherence to the screen, the involvement of primary care pediatricians, the quality of the sample collected, but also the psychological impact that it was measured through a questionnaire on anxiety, depression, and quality of life. As a secondary objective, obviously was to detect the children who tested positive for type 1 diabetes and celiac disease autoantibodies, but also to identify children which were predisposed genetically predisposed to celiac disease. And the end is to implement a follow-up to monitor a program for children who tested positive. Now I will show two very iconic pictures for two diseases. For the type 1 diabetes is a downhill. So scientific evidence has shown that, and this is very important also for celiac disease, because here we have an example of staging of the disease. So scientific evidence has shown that an important opportunity for the early diagnosis of type 1 diabetes is represented by the measurement of specific autoantibodies. And these autoantibodies precedes the clinical onset. And this is very important because it has led the definition of the natural history of type 1 diabetes, which includes 4 stages. In the first stage, we have one or two autoantibodies with a normal blood sugar. In the stage 2, we have 2 or more antibodies, but it's present as glycemia. And in the third stage, we have the clinical diagnosis. And in the first stage, we have the beta cell function that continue to decline with time after diagnosis. And how we can see, we have 10 years risks. So this process takes a time. But what about celiac disease? In the case of celiac disease, we have the very known picture of the iceberg. So identifying celiac disease very early, even in the asymptomatic individuals, is vital for preventing long-term health complications and also improving the growth and the development of children. Since celiac disease is still high underdiagnosed, only 40% of affected people are diagnosed and therefore adequately treated. Since symptoms may be often extraintestinal, so many cases are clinically silent. So we need targeted case finding strategies for early diagnosis. And this is done especially through celiac antibody testing, which is high sensitive and specific. So what about the pilot? This is the study design, and the study was based on the scientific literature and was conducted in 4 Italian regions, which are Lombardy, Marche, Campania, and Sardinia. And more than 5,000 children were planned to be enrolled across 3 age groups, and these were 2, 6, and 10 years, and which were the inclusion criteria. Where a written consent, informed consent, a privacy statement signed by both the parents. Also, we have provided a provision for assent to children who were capable of understanding the content. The only exclusion criteria was a previously diagnosis of type 1 diabetes. So which was the study design? The study design is centered on blood collection via finger prick into microtubes for analysis for type 1 diabetes and celiac disease autoantibodies, but also on dry blood spot cards for the assessment of genetic of DQ2 and DQ8 haplotype. So ISS prepare and send kits for screening to all the pediatricians, and the primary care pediatrician played a very important role by recruiting children, obtaining their informed consent, administering the very important questionnaires, and then collected the capillary blood samples via finger prick. So they sent the samples to the central laboratory, which was the San Raffaele Hospital, and all data were collected through a dedicated platform. Children tested positive were referred to the specialized center. So what about the timeline of this study? I will be very short. We started in November with an agreement with the Ministry of Health. from December to March, we carried out all the necessary action to perform the pilot, and we started the enrollment in May 2024. And after 10 months, we ended the enrollment with more than 5,000 of children. In July 2025, the pilot ended, and now we are analyzing all the data. What we did, first of all, we did a dedicated ISS web-based platform, which was developed specifically for DIScreen and was used to enter the data and communication with participating physicians. But also, it was performed also a dedicated website to provide improved levels of awareness and engagement about the relevance of the screening procedure for both diseases. And ESS also has developed educational materials, including brochure, poster. These were targeted to children, families, and general public using accessible and engaging communicable strategies. Then we had to create the network, and how we did. First of all, we established agreements with the association to identify primary care pediatricians who will to take part in the project. Then we set up a dedicated email, and we provide online training session to the primary care pediatricians. And then we had 5 regional fellowships that serve as a liaison between the primary care pediatrician and the central coordination and the specialty clinical center. But also we distribute monthly update newsletter to the pediatricians. So what about the results? First of all, primary care pediatricians, they were the primary care pediatrician who participate were 29 on 565 enrolled, and each pediatrician enrolled around 20 children each. We sent also questionnaire to the pediatrician to evaluate demographic information on where they worked and their screening experience. Most pediatricians work in medium-sized towns and are part of group practice, and many have support staff as nurses or administrative personnel. The screening, what about the screening? About usefulness and organization. About the usefulness, the screening was judged to be very useful by both the clinician and also for families. And furthermore, most participating pediatricians rated the organization of the study as good to very good, as the service for the support, for the family clinic communication, and the study-related coordination. What about the recruitments? Results are very encouraging. We ended the enrollment after 10 months with all the children that were planned, and was easily achieved and even surpassed. So an average of 94 children of the recruited children belonged to the 3 target age group, and it was represented with an equal representation of both gender. So this is a very good achievement. What about the sample collection? The sample collection, the capillary collection by finger prick was generally considered feasible. So by 80% of the, more than 80% of the pediatricians. And what about the quality of the samples? Almost all collected samples were suitable for laboratory analysis, both for the serum and both for the card, for the genetic testing. So this is a very good achievement. What about the screening, the results of the screening test? The project also identified, albeit on a limited scale, children at risk who were referred to regional specialistic center. But I have to underline that these are results from screening tests, and confirmatory analyses are being performed to the specialistic centers. So these are not the definitive results, but these are results from a screening. As with all screening tests, is normally associated with a higher rate of false positive. So the screening for celiac disease show a higher than expected proportion of positive cases. We have 219 children who tested positive for all the transglutaminase, both IgG and IgA, and all these analyses will need to be verified through routine analysis. So we identify these children positive to the test, but 139 were positive for IgA, and 56 were borderline for IgA, and 46 of the positive to the IgA were also positive for IgG, and also for the borderline. All these children are referred to the specialistic center to have a confirmation test and eventually a follow-up. What about the genetic predisposition in these children who tested positive or borderline for the transglutaminase IgA for CD screening? We see that they were the 89% in the genetic susceptibility to DQ2 and DQ8. And those who represented non-genetic susceptibility were 11%. I repeat, these are not definitive results, but these are coming from screening results. In fact, 11% have not genetic susceptibility. They were 21, but at a second level test, these were reduced, which was very precise, always on the same sample of the finger prick test. It was reduced to 3.5%, and the 52% of this group was borderline at the first level to IgA screening, and these were 11. So we will see the confirmatory test at the specialistic center. What about type 1 diabetes? It should be noted that the test that is used for type 1 diabetes screening detects the presence or absence of one or more autoantibodies, but does not specify which one is. As with all screening tests, is always associated with a higher rate of false positive. And for this reason, a second level analysis was performed on the same sample with ELISA assay to identify the single antibody. Thus, the screening, we see that the presence of one antibody was confirmed in 15 children, and the children who were present with 2 or more autoantibodies are 10. I can say that 2 of them are going to the 3rd stage now. So we see that in that case, we have not an ketoacidosis presentation, and this is very good. And all these children will go to confirmation test with, they are gone to the confirmation test and their follow-up. So what about the psychological assessment? The psychological assessment was conducted using 3 validated questionnaires on anxiety, depression, and quality of life, and these were administered at the enrollment and when the pediatrician gave the answer, so T0 and T1. The data showed a reduction in symptoms of anxiety and depression, and families also report less discomfort over time. And this suggests that screening does not negatively affect psychological well-being, and in some cases may also improve it. So I hope I didn't bore you. And what about the conclusion? As already said Dr. Silano, Professor Silano, the feasibility of scientific evidence in a public health program is real. So key success factor included the high willingness of families, the strong involvement of primary care pediatricians, and the reliability of capillary blood sampling. And these findings support the possibility of extending screening on a larger scale within the Italian National Health Service, so in the Italian territory. To improve the early diagnosis and also to prevent complication from both these diseases. I want to thank you for the opportunity to share our experience, and I have to say that I am not alone. There lots of people worked on this project because it lasts only 1 year. And we have the work group of the ISS, together with me and Flavia Pricci, Marco Silano, Umberto Agrimi. We have a scientific supervisor, all the clinical center of the 4 regions, the laboratory, the centralized laboratory, and all the pediatricians who help for this screening. So I want to thank also Fondazione Italiana Diabete and also AIC for their support and help. Thank you so much.
All right, so the first question comes from Iterson, and it's mentioning regarding the study discussion designed. What was a minimum amount of gluten children had to consume via dietary questionnaires? I assume TTG results might be less reliable if there are children who consume little gluten.
In this phase of the screening, it was not foreseen a questionnaire, an elementary questionnaire. But this is a very good idea. This was only a screening. For the national screening, I suppose this will be very, very informative. Thank you.
Fantastic. There is another question from the same person regarding ethics. Will the children with positive TTG outcome be made aware of this or their parents?
Absolutely, yes. The primary care pediatric will call the family, and you will explain what's happening, and he's saying if they want to be contacted by the specialistic center to the follow-up. So they are free to participate or not, but most of the parents
Yes.
gave the children to the specialistic center.
Yeah, if I may add something, this is a very important question because as Olympia knows, the ethic committee has raised this point. Because as you know, when the genetic is involved in a screening, this is a very sensitive issue. And yes, we will inform the parents about their own children positivity for the genetic predisposition, because also we have a national guidelines for the diagnosis and follow-up of celiac disease, and these guidelines clearly foresees that the genetically predisposed children should undergo antibodies determination every and each 2 years to early detect the celiac disease. So they are informed, and also they are kindly and warmly invited to address to the national health system to perform the determination of anti-transglutaminase antibodies each 2 years to early detect the onset of celiac disease, because they are at high risk of celiac disease.
Fantastic. Thank you so much. Very comprehensive answer. There is another question. Is there idea that this screening will become routine for all newborns, just those with a family history? And is it cost effective at this scale? So 3 questions in one.
Yes, this is the innovation and the central point of this law. The screening will be offered to all the newborns in Italy each year, with no distinction and with no exclusion. All the newborns with no exclusion according to the region of birth, to the socio-economic levels of the parents, or according to the education levels. No one will be left behind in this screening program. And this is something that we have to be very thankful about to Honorable Moulet and the political decisors and the Italian Parliament, because for the first time we in Italy the screening for celiac and diabetes type 1 will be offered to all children, not only the high risk children. In the world there are several program to early detect celiac disease and diabetes at high risk children. In Italy, we don't do the risk stratification before offering the screening, but we will offer the screening to all the children. This is the most important, and I can say the edge-cutting innovation and high protection of this program.
Excellent. There is a question difficult for me to understand, but probably clear to you. What will you do if someone tests positive for one T1D autoantibody, as this is not strongly indicative of progression to T1D?
In this case, all the children who tested positive were referred to the specialistic center for confirmatory test. So it's not strongly indicative of progression, because in this phase we do not know. So they need to go to the specialistic center for confirmation.
There is another question. Did you investigate the reasons for non-participation if parents declined the screening?
This was not the case, since all the parents that the pediatricians called decided to participate to the screening. This is perhaps only 5,000 children, more than 5,000 children. We don't know in a major scale, but in this case, every each parents wanted to participate.
Another question. I say thank you so much for being so participated and get this opportunity. How much did the 10-month pilot with around 5,000 participants cost? Has a health economics analysis been carried out?
I will leave the floor to Olympia shortly about the details of the cost of the pilot study, of the propedeutic study. However, I want to add that screening of celiac disease and diabetes type 1 has been proved to be a huge advantage for the children that undergo this screening. So economics is one of the players in the field, but the main driver of the decision is the protection of the newborns and the ethical aspect of the children, of the screening for the children. This law and this law will offer a level of protection for an early detection of clinical celiac disease and of diabetes type 1 that, in my opinion, and also I think this is the opinions of the decisors, that it's an ethical issue, is an ethical mandate. So economics is important, but ethics is even more important.
I have to say that we have different voices of costs, okay? We designed to perform the pilot on scientific evidence from other projects as ASK, as FRIDA in Europe, ASK in Colorado, or FRIDA in Europe concerning type 1 diabetes. This is the first time that they go together. So they did the economical impact and the voice for voice. But in this case, I have to say that we have the expenses for the regional coordinators and the expenses for to send the kit and for each analysis. To the territory, the expenses will be very different. So the other studies, they say that each children could cost 28 euros from the FRIDA studies for the type 1 diabetes. Yes, we are looking at the cost, but we have to look at the benefit. So what about the costs of a child who has ketoacidosis? What about the cost of complications from non-diagnosis of celiac disease and its complications? So we have to reflect on this. There are now there are lots of papers that are speaking about the economic impact of screening. But at the end, we have a positive impact, which is the best thing to do, I think.
Thank you so much. And there is a person that would like to get clarification. She says, just to clarify, there will not be one time point that children are screened. They can be screened as part of this law annually at a well-child visit with PCP. Also, given that newborns are not yet exposed to gluten, will celiac antibodies be included at newborn or just genetics?
I start from the end. I can say that newborns will not obviously be included for testing autoantibodies. That's really true. What about the age to be screened? In this study, we tested 2, 6, and 10 years. So why these years? These are the years where we have the seroconversion for type 1 diabetes, but is also true for celiac disease. So they cannot be screened as part of this law annually, but they need to have a specific age, a range of age.
There is another question. If the children were recruited by pediatricians of the general population, or if the kids were already showing some indication of celiac disease. That's also a question that I had.
Absolutely at all. They were children from general population. This is the screening. This is the meaning of the screening.
Very good. I don't see other questions, but I taken the 2 minutes left because I would like maybe to all of you end with a few words of what is next and what will be your advice for maybe other regions or other nations that would like to follow Italian leadership on this. If you already can share some pearls of wisdom, some piece of advice for the audience.
So can I ask you, Onorevole, and if you can address some conclusion remarks about what will be next, and also the indication as Veronica has asked to the other countries that would like to implement something such this screening.
Okay, obviously, and thank you, Veronica, and your guests. So the next step will be not a conclusion. This is just a beginning. It was hard at the beginning, but as Marco said and Veronica said, Olympia said, we had a very push commitment, and they did the first goal. But now, as they told, we have to start from January. And I'm fighting at this moment with Italian bureaucracy to complete the final steps to start the very game that involved every part of Italy, every part of every region of our 20 region. So we just have talked with some countries, not only in Europe. On the 24th of October, we will have a meeting in the UK from our scientific side. Professor Bossi will meet a parliamentary and scientific community to start to share our law. And in UK Parliament, in House of Representatives, 2 months ago, Prime Minister Keir Starmer was answered about this law, and they said we have to copy the Italian law. We just talked with the USA. The USA, with some countries of the USA, they are very interested in this. And many countries in Europe, across Europe, we sent to the European Parliament our law, and we started to share with the other parliaments across the continent. So we are completely at disposal of your association, of your network, and me, Mr. Professor Silano, Dr. Olympia Vincentini, and all of us is at disposal of your network to share our competence, what we do, and what we will do. This is very important. Is the key point of our discussion.
I thank you again. It was an honor and a pleasure to have you, all three distinguished speakers, and also a very engaged audience that stayed just to the end, which is a very good sign. So thank you again, and we see each other in 3 months.